Hello, everyone. My name is Lawrence McGaffey. Today, I'm presenting my data proposal, which examines whether integrating faith-based practices into community cognitive behavioral therapy programs, if it influences 12-week completion rates for justice-involved teens. We'll be going over the topic of study, the problem I'm trying to address, the purpose of the study, population and sampling, research design, data collection procedures, data analysis, and dissemination. My study focuses on integrating faith-based practices into standard cognitive behavioral therapy programs for justice-involved teens. In juvenile justice ministry, I see how structure and support and consistency and relationships, how that matter for youth rehabilitation. This topic, it ties directly into both my ministry, juvenile justice ministry, and transformative leadership, where we're supposed to inspire, change, and advocate. The problem that I'm addressing is low completion rates in CBT programs. CBT is effective, but many of the teens don't finish the program. And incomplete treatment is linked with increased recidivism, according to the Office of Juvenile Justice. Ferolino and Yap and others show that faith-based support can strengthen motivation, resilience, identity, but we don't have measurable data on what happens when faith-based elements are added to cognitive behavioral therapy or CBT programs. And not only is there a lack of research on integrating faith-based programs, but there's also limited research on completion rates, which I found odd because if you're rehabilitating anyone, you would want to know the completion rates of programs that are successful. And while there's some research, there's not a lot of research on how many people are completing, in this case, youth, how many teens are completing CBT therapy, so it's kind of difficult. But that gives us an opportunity. The purpose of this study is to examine the relationship between faith integration and completion rates. CBT is already supported as effective. It's already proven to reduce recidivism. But what's unclear is whether if we add faith-based elements, if it increases the likelihood of completing the program. And our stakeholders include facility administrators, those who run detention facilities, chaplains, those who provide faith-based programming inside detention facilities, probation department, those who are responsible for overseeing justice-involved teens on probation, community mentors, those who are outside in the community who are interested in helping youth and being a support for youth and being a mentor or role model for youth. And then families, of course, as our last stakeholder, which is probably the most important. My methodology. The population includes justice-involved teens ages 11 to 17, and I'm restricting it to community-based CBT programs. All of these teens have trauma histories. As a matter of fact, all of the teens that go into the justice system have some type of trauma which affects their behavior. They have trauma histories, they have academic struggles, and then on top of that, they have these probation requirements. An intended sample is 25 to 40 teens enrolled in CBT programs or CBT with added faith-based practices. I'm using a selective sampling strategy because the youth, the teens in this case, they must be between 11 and 17. They must be on probation. They have certain criteria. They must be assigned to a CBT program, and then they must also decide to be involved in a faith-based practice. And then program administrators will also help to identify which participants are eligible. Research design. My research question is, what is the effect of integrating faith-based practices into CBT on 12-week treatment completion rates among justice-involved teens? The independent variable, the variable that I'm manipulating, so to speak, is CBT only versus CBT with faith-based practices. And then the dependent variable is whether the treatment was completed or not. The study has a quantitative correlational design and is designed to explore whether these variables are related in real-world practice. My data collection procedures. Data will be collected from program attendance logs, from discharge forms, from intake demographics, from records already maintained by other CBT programs or by other programs in the facility. I gain access through these permissions from the program administrators, from the facility administrators, and from the legal department. All of them work together and have to sign off on anything dealing with these teams. And then also, each of the teams would be assigned a participant ID in order to protect their identity. So the first thing would be to secure permission from administrators and from the legal departments. Again, the administrator is the one who runs, they like the head person who runs that facility. And then the legal departments ensure that they're doing everything according to the law. So first secure permission from them, then review program files and extract all that demographic information, the treatment types, the attendance, completion statuses. Then I'll enter all those variables into an Excel spreadsheet and then clean up the data and verify the accuracy of the data. And the timeline, we can start with weeks 1 and 2, getting approvals and getting setups, communicating back and forth, and then weeks 3 to 4 for extracting data, and then by week 5, we should be coding and cleaning data. Data analysis procedures. So I'll run descriptive statistics first, getting frequency, getting means, measure central tendency. And then for inferential analysis, I'll use a point by serial correlation because it's dichotomous, is treatment type and completion. And then we'll move on to coding. So of course, all of the variables need to be numbers and organized, in Excel. We'll run the correlation and then review the strength and the direction of the relationship. We want to see how strong that relationship is. And then we'll determine significant using an alpha level of 0.05. To check for errors, to make sure errors are not abundant. We'll double check the data entry, We make sure we document our coding practices, have a ledger, and then follow the statistical assumptions. Not adding any bias into our research. Of course, I want to say yes, adding faith-based practices to anything that's positive will lead to higher completion rates. But I have to follow the statistical assumptions in order to remove my bias and actually see whether or not that's true or not. And lastly, dissemination. So, of course, the findings will be shared with facility administrators, with chaplains, with the probation officers, and the community partners. And then if relationship is found, these programs may consider integrating the faith-based practices more intentionally into CBT programs. And as a transformative leader, I would then use these results not only to guide volunteer training and curriculum for the teens, but also in policy development, in advocacy for the teens in the community and in the courthouses, and then community partnerships. The study, in other words, could help shape a broader conversation about rehabilitation, about youth development, and about the role of relational support in behavioral change. So to summarize, the research is designed to tell whether faith-based integration is related to CBT completion rates. And if we understand this relationship, we can better, I don't want to say control, but we can better support positive youth outcomes and long-term success. And then the significance is that this research will provide data-driven insights. It will add to CBT research and also add to the little of research there is about completion rates and about faith-based practices and its effect on completion rates. And then also how we can get more engagement in these programs. That's a big thing. Getting teens to want to go to therapy. So if we can add another element like faith-based programs, we can strengthen that engagement in CBT therapy and the retention as well, which will increase completion rates.